Welcome, everybody, to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. It is February 20th, 2026. It's a little after 11 a.m. on the East Coast. If you're watching this after we've been live and you have any questions, you're welcome to email us at support@4hcm.org, and we'll address your questions later. I am Lisa Salberg. I am your host for Tales from the Heart, and today I am joined by Dr. Michael Ayers, who has a little update on his CV to let us all know about and make sure everybody knows what's going on. And then we're going to talk about his most interesting topic or article of the, since last time we talked, not of the month, but since last we spoke. So, Dr. Ayers, what's going on in your life these days?
I'm going to give you a few updates. I'm going to end with the one that you are referring to, I suspect, last, but just to give you some broad overstrokes. Chris Kramer's run as ACC president is coming to a close in March, and so he'll be picking up more work in our HCM center, which we're very excited about. Senior excellent HCM attending, probably, but arguably one of the most famous CMR researchers, cardiac MRA researchers in the world in the HCM space. We're excited about that. Happy to have him back. We had James McNamara join us, which I know we had mentioned before. He is a superb physician out of UT Southwestern. He does a lot of work in exercise physiology, and so he and I have a nice little Venn diagram overlap in exercise land, and he's really invigorated our program. We did a big outreach push at the end of last year and met with a bunch of places in Virginia, and our business is booming, so to speak. We've got more referrals than we have spots, and so we're very excited to have James coming back. We're also, Lisa, picking up our second nurse practitioner to help with expediting follow-ups. As you know, these visits they can be overwhelming, the amount of information. When you come to see us, you're seeing a genetic counselor, you're seeing an exercise physiologist, you're seeing our research team, you're seeing the nurse practitioner, you're seeing me, you're seeing the lead nurse, you're probably seeing some people from our imaging center. It's a lot. And so we've found patients really benefit from rapid follow-up in the 1 to 4 month period, particularly patients that are getting a lot of new information, and the nurse practitioners are really helping us with that. So we're really excited about that. Those are updates. I will tell you personally, my wife voted, and I was a non-voting party, just teasing, in adding another family member to our house. And so we went for baby number 4, and we got baby 4 and 5. And so just a little word of wisdom to people out there. If you decide to go another round, so to speak, it could always be a double round. So just know that that's a possibility. And so we're tackling that at home, and it's going well. The last thing I'll say is my role at UVA has transitioned somewhat in terms of what I'm doing. I am still the director of our HCM center. I'm still involved in our 12 or so clinical trials. I still have somewhere around 2,500 patients, of whom 1,400, 1,500 are HCM patients. Kept all of that, but I decreased my effort to 25%. And I focus all my patient care on Fridays, very, very busy day. I read imaging once or twice during the week, usually remotely for those. And I've taken a job with a company called Edgewise Therapeutics. They have some really exciting products in the HCM and HFpEF space, as well as in the Becker's and other dystrophinopathy space. And I've taken on a role in senior leadership for clinical development with them to help them with their phase 3 trial that's coming up in HCM in particular. And so I will be splitting that. As such, I will continue to be as honest as possible on these, but occasionally, if I feel like what I'm saying could potentially be conflicted, I'm going to go, Lisa, what do you think? In some of those moments, to make sure we keep everything above ground. And we'd love feedback from everybody about how that's going. How do you feel the neutrality is? Because that's really, really important to this podcast. So I guess what I'm saying is HCM still has a big place in my heart, I guess pun intended, but I'm now splitting time between both University of Virginia and with Edgewise for their new product development in HCM.
So this is a little bit different beginning than we normally have for a podcast, but we thought long and hard about Michael's role in the podcast as he's joined us about a year ago as a quarterly segment, I believe is what we've been doing. And we've had some great conversations, and you've all enjoyed his input, and we've gotten great feedback. So when he took up the side gig with Edgewise, I'm like, how is this going to play out? We had a conversation. And number one, we want to be completely transparent that he is working for industry and he is in clinical practice. And we are going to continue having him as a guest on Tales from the Heart. If we feel that there's anything that ventures into the place of conflicting, as Edgewise is a sponsor as well, we're going to just caution that out, that we're not going to address that, or we will address it in a particular way. But we're going to be completely transparent, because what do y'all know me for? Just basically putting it all out there, making sure everybody knows what the playing field is. So with that, I think that we're going to go forward with a lot of great content today and in the future, Michael. So thank you. Congratulations on your new role.
Thank you.
Thank you for being part of innovation for HCM and helping us derive potentially new treatments. It's early days for Edgewise. We wish them all the best. You've got a great team over there that you're working with, we know, and we're excited to see what comes next for them. But there may be times where I say, Mike, we're not going to talk about that, or no, we're not going to go there. But we both know where those lines are. So that being said, let's pivot into what's the coolest thing that you've seen since last we talked. We want to talk about AI and differences in race, right?
So we're doing a bunch of work with integrating these AI ECG readers and programs into our health system. For those of you who are not familiar with this, essentially AI has read now tens of thousands of ECGs, and they've correlated diagnoses with certain ECG findings. And whereas physicians might focus on very traditional spots of integrating information, AI is sort of blind to that, and it reads all of the squiggles, and it's looking for any squiggle that it thinks is important or is tracking with certain diseases. And what we've found is, if you're very careful about where you draw the cut point, and I'm going to come back to what I mean as a cut point in a minute, you can create an instrument that's highly predictive of you have HCM. By that I mean, if the instrument says, Lisa, I think this person has HCM, there's a very good chance they do. Now, the sacrifice of that kind of a cut point of an instrument that's really good at saying you have HCM and you do, is you might miss some people who had more subtle findings that get labeled as less likely HCM. But the trade-off of that is, what you want is a tool for your physician where I know if it comes back as yes, it has to draw my attention, right? I have to pay attention to this. There are no false positives. And just admitting to everybody, you lose a couple of people in the side there in terms of they were labeled as less likely, but they have HCM. And so what we talk about is a positive and negative predictive value, which means if it says yes, how likely that it's really yes. And these instruments now are 95% plus positive predictive value, which means if they say yes, I should be listening. The negative predictive value is still somewhere around 70%. And so it's going to miss some people. It's going to say you're a no, but really they were a yes. However, that's a trade-off we were willing to make at this point in time to get more adoption. All right, so that's kind of the background of AI ECG in general. The idea is this would live in a cloud, and it would read all of the ECGs for a center or even for a health system, and it would have certain nudges that it gave certain people when it had findings. So we're starting to get ours off the ground here at UVA officially. Dr. Kent is working pretty hard on the health system side to integrate that in UVA, and we're excited about that. We think it's going to be part of guidelines in the future. I've participated in guideline committees, and that I think that's the motion. That's where things are headed. So what we did was this study, and so now to my study. I'm giving you a self-serving study because this was my medical student who did this study. She is, by the way, just a fantastic medical student for any program directors listening out there, Myra Lewanton. What we did is we looked at every referral over a 2-year period to our center, every ECG that person had ever had. And the question we were asking is, had there been AI in place that was reading every single ECG on that person ever, would the AI instrument have diagnosed HCM before the health system did? Now, there's some problems with that study, Lisa, because a lot of people are entering the health system just to see me, right? They're coming from afar and they're coming in just to see me. And so the first time they're being seen, I'm seeing them at the same time as the ECG. And so what we found is, by and large, about 60% of people were getting diagnosed within 6 months, ECG and clinician. They were very linked. But there was a group of people that were having dramatically changed time to diagnoses. And what we found is, if you identified as a woman or if you identified as a non-white male, you were being diagnosed years, and in one case, 2 decades before you found your way to the HCM center. So we thought this was a nice proof of concept that the AI instruments were performing how they were predicted to perform in terms of sensitivity, specificity. Do you have HCM? Do you not? And we also found it very interesting that it seems like AI might have some social, racial, economic implications in terms of making the playing field more level, so that people are coming to attention earlier, because we know this is an underdiagnosed and a delayed diagnosed disease. And we know that there's some racial and social issues in health systems in general in terms of making sure people are being treated fairly in terms of times of diagnosis. So we were excited about this. We think it's a great proof of concept. We're hopeful UVA is going to grab articles like this and use it to encourage themselves to adopt AI moving forward.
So I love this and I'm afraid of it at the same time. The false positives, the false negatives. They are going to happen no matter how good we get a system. And I have been thinking about this one quite a bit lately. When do we use this more homogenously throughout the health system and accept a certain level of predictability and error and communicate that so people understand we did this, the likelihood of it being correct is X%. And when can we whittle it down and say, for a white male, it's 97%. For a non-white male, it's 80% predictive. We do that in other forms of medicine because we've gained enough knowledge and have enough data to make those decisions. How close are we to knowing what those tolerances are?
Yeah. So right now, the biggest concern is click fatigue with physicians. And I'm just being completely transparent with you, Lisa. The worry was you were going to roll out a perfectly sensitive instrument that sent me 100 people every day, of whom 25 had HCM, right? And it wasn't missing any HCM patients, but I was constantly getting bombarded with, this could be HCM, this could be HCM. We were worried that was going to result in physicians not adopting the tool. And just to say it out loud, this is a disease that's 1 in 500 people, and we diagnose at rates of 1 in 3,000, meaning 1 of every 6 people with HCM has been diagnosed, and 5 of every 6 are walking around without a diagnosis. So anything to move that we think is helpful. Mm-hmm. And we just wanted to create cut points where we knew that the people being sent to physicians were very likely to have HCM and were very unlikely to be false positives. The trade-off you just nailed is that it might give some physicians the false reassurance that we're getting all HCM, which we're not. We're missing some HCM, but we're doing that to trade off, making sure that the nudges are as high yield as possible. What will happen with time? Will the instruments get better? Will they get more specific? I don't know. The people who work in AI tell me they will, and that they'll get smarter at doing things like, ooh, there's a nudge on Lisa. I'm not just going to ping Michael. I'm going to read Lisa's chart, and I'm going to have clues that increase or decrease the probability that this was a true positive before I ping Michael, right? And so there's talk about using a full chart approach in AI to start making this as sensitive and specific as possible so that we don't miss anybody. But right now, that's just not the case.
I love that idea. I love the next step of the research. I do have a concern over false negatives and where they're going to land in the system. But we are evolving, we are learning, having those triggers ready and how to deploy them. I love looking for those alternative risk factors. I guess I'm going to call them at the moment. I don't know that we'll keep that term risk factor. But we know that if somebody's been diagnosed with athletically induced asthma, anxiety, and they have a family history of heart disease, ding, 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 we see a path, and now we have a glitchy ECG. Those are the people that need to meet Dr. Ayers. And the other people who have the glitch, but nothing in the background, maybe the risk is lower. I love that validation. And if we are going to bring AI and tech into healthcare, there are safe places to put it. And I don't think we should give it blanket trust.
Right.
We have to have specific utilization for specific tools, and then we can move on. We're involved with some really interesting research questioning small machine learning, large machine learning with AI in different disease states, and what decision making can be led by these technologies. That's about a 5-year project that we just started. It actually begins in March, so I will be giving updates on that as well as we move forward, but it's really fascinating to see where we're moving with AI. Deb has a question in that area, and then we'll be moving to other topics. Is there concern that some physicians may use AI to rule out HCM without further examination, especially for women? Asks a woman named Deborah.
Yeah, so physicians are taught that certain tests have certain sensitivities. And by sensitivity, I mean, how good is the test at getting all the people who have the disease and labeling them as yeses? Knowing I might get some false positives, labeling them all as yeses. Physicians are taught to think about that. My worry is that physicians are going to see AI, they're going to see computer-based AI program, and they're going to go, oh, this must be the truth. This must be the diagnostic gold standard, right? This must be 100% sensitive, 100% specific, which no test is, right? And that they're going to see that, and they're not going to plug AI into the same thought processes that they should be using all the time for every test. As an example, today, Lisa, I saw a patient who has the first abnormal EKG was 1987, and the echo does not show HCM. It just doesn't. And the reason is the echo is cutting here, and the thickest segment is right there. It is just missed on the echo. Finally got an MRI 30 years later, and it's very clearly HCM. That's an instance where a physician needs to say, gosh, I've got an abnormal EKG. I have a funny family history. The echo was normal. I looked at it and it was normal. That's not a perfectly sensitive test. I have to pivot to MRI. I'm giving you that example because physicians should be using all tests in a sensitivity, specificity. How good is this test? What was my pre-test probability? How much did I think they had HCM beforehand? They should be doing that all the time. They're just going to have to be taught that AI is not perfectly sensitive or specific.
So the question has come up. Santosh, we're going to get to some of your questions in a little bit, but I'm just going to be very clear that says we can't get into very specific disease management questions in a podcast. We can talk about generalities. So I'm going to homogenize that a little bit later, but we will address the one question here. What are risk factors and risk management? So I use that term risk factor for a different term here, but can we just pivot for a second? When we talk about risk factors for sudden death, they're published, they're understood, they're known. Risk factors in a family for risks for heart disease are different. They're the signs and symptoms, the family history, stroke, cardiac arrest, heart failure deaths, somebody who's always kind of been a little sickly but never got an actual diagnosis. Those are the family history risks I'm speaking of today. We're not talking about sudden death risks. That's a different conversation. Okay, so Michael, going back to AI and identifying the right populations. So I've been contacted by some people who have some ideas that they want to do ECGs on everybody, everywhere, and figure out all the hearts. That sounds aspirational. It also sounds like we have some workflow issues to consider before we embark on such an initiative. When should we be using EKGs in our general healthcare, whether they be AI read or not?
Oh, Lisa, that is such a difficult question.
I know, but it's fun to ask them.
So if I send Matt Martinez to go do sports screening, I am 100% comfortable with him getting an ECG in every single person he sees that day. The reason is Matt Martinez has seen tens of thousands of athlete ECGs, is going to incorporate the full athlete story, and is going to be thinking about what kind of anxiety can I create when I take a low risk situation and tell somebody this could be something. And he's going to use really, really good judgment. Don't let him know I said all that about him.
I will keep that secret.
And so with Matt, the answer is as many as Matt wants, right? However, pivot that to you're at a fair where people are doing health screenings and they're indiscriminately doing ECGs. I get lots of people coming to me with benign ECG findings who have been terrified for weeks to months because they were told you need to see a cardiologist. And so I guess I'm squirming out of your question to say it's totally context specific.
Yeah.
When you have people that are trained to interpret these things in their full milieu, in their full context, ECGs are a great tool, and I'm not very worried about their misuse in those instances. When you have people who aren't trained to incorporate that data, they can cause more harm than good. And so it really has to be thoughtfully rolled out. It can't just be a blanket statement.
I couldn't agree more. And my guidance to people generally is work with your chosen healthcare provider to provide that screening and the follow-up that may or may not be required. If you're going to a community screening, you're not 100% sure where those echoes or EKGs are going. You don't know who's actually reading, what protocols were used, and are those protocols appropriate for your disease state that you may or may not have. So the nuances do get a little complicated, and there's a lot of good people doing a lot of good things out there, but people don't fully understand that cardiac anatomy isn't black and white. It's a billion shades of gray, which is why my wall is gray behind me, but that's my symbolism. Okay, so it is.
Lisa,
yes.
Lisa, when you start thinking about math of rolling ECGs out to everyone, part of what you have to think about is what is the baseline rate of the problem, okay? So if I took a test that was 99% sensitive, okay, and I gave it to 1 million people, and I told you only one person out of that million had the disease, you're going to get 1,000 positive tests, and one person is a true positive. So you just took a test that has 99% sensitivity. Gosh, that sounds great. And all of a sudden you have 1,000 people who have been told you have a disease, and one of them do. So you have to think about the background rate of the problem when you're rolling out tests. You can't just say, wow, these are great test characteristics, let's give it to everybody. You have to incorporate that information about how likely is this to begin with before you even start with your decisions.
While it shouldn't be the first concern, it has to be talked about in today's world. When you go out to when you're going to a hospital and you're getting a test, it's one set of issues. And I love the AI read there. I think that makes all the sense. When you're going outside of a structured healthcare system and you're doing additional screenings and there's a different pathway, you could end up with thousands of people requiring additional screening, and the cost and the labor associated with that may not be available in the region that you are in. We are dealing with healthcare crises. We are having lack of physicians, lack of nurses, lack of ability to get into appointments. And we have to think logically about how to get to that next step of getting more people in an efficient way and really triaging those who have higher risk profiles. It is an evolving conversation. I've been here at the HCMA 30 years this month. This conversation has evolved exponentially over that 30 years. We're moving the mark. We're getting better. Are we at the goal point yet? No, we still have ways to go. So I just encourage everybody to talk with their own physicians, work with their teams, work with their communities to have better understandings and better systems. And we look forward to the partnerships we have with many people in that space.
Health access is such a big thing, Lisa. I mean, if you go back to the case that I reviewed this morning from a patient several months ago, where I said the echo was normal, that patient had access to an MRI and got diagnosed. there are huge swaths of the country where cardiac MRI is just not available. And so does that mean that person in that instance, in that location, just doesn't get diagnosed? The answer is actually yes, they don't get diagnosed. And so healthcare equity and access is just a huge, huge issue.
So April will be heading back to Capitol Hill to talk to them about our needs and equitable access to high quality care for everybody in the country is critical to us. It's absolutely critical. And we all are going to need to work together to build the healthcare system of the future. We're not going backwards in healthcare. We are going to the future. How do we use it effectively? That's going to be the global conversation. And I look forward to being a part of that global conversation along with you and many others. Pivoting now to happier somewhat topics. Michael, I find HCM Awareness Day and Heart Month a challenging time for me personally. There's so much that we've done and that we're happy about and that is moving in the right direction. It's a good time to have a thick heart because we got so many treatment options and better diagnostics. But I'm also living in the real world where there's a lot of scars, physical and emotional, that are related to life with HCM and the family struggles that we've seen and those we've lost along the way. So Heart Month to me, I get a little emotional and melancholy because it's both those who aren't here, those who are here, and those who are fighting for tomorrow. So what does Heart Month and HCM Awareness Day mean to you?
Yeah, it's a big package to open. There's a lot underneath there. I think most importantly, you've probably heard me say this on this show before. HCM is the most common inherited heart condition, but it is so frequently misdiagnosed. It so frequently has patients who are even correctly diagnosed with delayed diagnoses, and it's so enormously underdiagnosed that for me, the month is just, how can we do better? How can we get the right patients to the right provider in the right time? And that's ultimately what the month makes me think about over and over is right people, right place on the bus, right? How do I get people where they're supposed to be?
I like the analogy, but it's like, what stop am I getting off at? Am I on the AFib train or a bus, or am I on the myectomy or the myosin inhibitor or the genetic family history following the trail? Like there's a lot of different paths to follow in HCM and they impact us each differently. I've got some secrets and fun stuff that I'm going to be unveiling on HCM Awareness Day that lead into this. So I think people will start to get a kick out of that. I will give a shameless plug for, maybe Demi can throw that into slide mode so we can see it prettier. HCM Awareness Day is next Wednesday, February 25th. It's quick approaching. If you are in New Jersey and you want to join us live here at the HCMA office, you can come on by and enjoy some wonderful food from Sergio's. Any locals who know Sergio's in Denville understand that that's a big deal. We are going to tell you all about the work that we're doing. You're going to meet some of your big-hearted friends and industry representatives. So please do come on out. And if you can't be here in person, we're going to have a webinar, which is going to be a little different than our typical webinar, as we finally got the piece done like it's happening right now. We are going to be airing a documentary called All Hearts, and it is connected to our All Hearts Collaborative Initiative, featuring two amazing families with two very different stories and some other great stuff about what we've done in the past year and what we're going to do next year or this year. So please join us for that. And we've also got our Party in a Box, which are on the wall behind me, some posters, some tabletops for you to bring for your workplace, clinic, school, wherever you want to raise awareness about HCM, and also our new wristbands. So you got everything in a box. There's a couple left. If you want to get them out today, put in your order now. Maybe Demi can drop a link for that as well. And come on out. Come do something locally. Just even post on social media on HCM Awareness Day, like what your story is and why you care, or share some of our content. Like, what else goes on during Heart Month for you guys? What's important to get out, and just general heart health messages?
It's interesting to me how often the non-HCM cardiac problems are, I don't want to say ignored because that sounds mean, are not the focus. And another thing that I think about a lot in this month is the whole patient. How do you take care of everything, right? From uh, depression to sleep apnea to regular cardiac risk factors like blood pressure and cholesterol to what they're dealing with socially in terms of navigating the family screening and what limitations they may or may not have at home. HCM is such a it's a disease with so many therapies now and so many areas of need that it's easy to get lost in just HCM world and to forget the bigger picture. And so another thing that we just really started to push more and more in our HCM clinic is these sort of check boxes and multiple providers thinking about, all right, am I taking care of everything right now?
So I think that's a really great point. We can have high cholesterol. We can have other things going on that can impact our cardiovascular health. I did not find out until after I was transplanted that I have lipoprotein A, and I'm on Repatha. I'm an expensive chemical mix here to keep everything in check. But I never checked it before because it really wasn't a thing before. So can you tell everybody a little bit about what lipoprotein A is and why it's important to know about?
Yeah, I'm going to start with an even broader comment just to reflect what you said because I thought it was so meaningful. Most patients that I see that are in their 50s, 60s, 70s, I get to say something to them that's going to sound a little strange, but it's a compliment from a cardiologist, from an HCM specialist. I get to say, look, at the end of the day, you're much more likely to die from all the things that kill all the other Americans, run-of-the-mill heart disease, run-of-the-mill strokes, run-of-the-mill cancer, than you are this HCM. And so we're going to cover this today, but you're also going to see me talking about some of these things. You're going to hear me talking about some of these things because those are actually more pressing for you. One of those things that frequently gets ignored in the lipid sphere is a lipoprotein little a. Lipoprotein little a is about 1/100th of your cholesterol. So it's a small makeup of your cholesterol, but it's a really bad and angry actor. By that, I mean it causes a lot of problems. It's probably responsible for somewhere around 5% of America's heart attacks, give or take. It turns out that your LPA is almost entirely inherited from one of your parents. And so your LPA level changes very little through life from pediatrics into adulthood. It does go up when you get sick. So if you have the cold or the flu, it'll kind of spike up and spike down. But for the most part, it's very steady through life. And we know that it's a risk multiplier for traditional risk factors. And so how do I use it in clinical practice? Well, as of right now, we don't have firm evidence that lowering LPA mitigates risk. We think it does based on some plasmapheresis trials from Germany. We think lowering LPA matters. And there's 97,000 people in phase 3 trials right now for LP lowering. So we should know the answer very soon. But what I do is I identify it as a risk factor. I say, I'm not sure that lowering this with a PCSK9 inhibitor like Repatha is going to help you. But I do know that this magnifies your risk and makes me want to be more aggressive treating regular cholesterol, regular diabetes, regular weight, regular blood pressure. So if you're somebody who is on the cusp of I need a statin for my cholesterol or I don't, and I check an LPA and it's elevated, well, now I say, look, I can't help you with the LPA, but I know your risk is higher than we thought it was. So let's go ahead and treat the cholesterol. And so I'm frequently using it as a tiebreaker in clinic to really participate in shared decision making, for which HCM, I think, has become a model in the cardiology community.
I like that answer. So when you have HCM, you have to check your other cardiac risk factors. We want to move, we want to walk, we want to be active, we want to eat well, we want to sleep well, we want to balance our life. And when we do that, we're probably going to be ahead of the general population in heart health because we're paying attention to it. So I encourage you to share that message with others. I gave a talk yesterday morning down in Newark through our All Hearts Collaborative to a group of ministers in Newark. And it was our turn to buy breakfast. I think I disappointed them just a little bit because I went for heart healthy and they were looking for good Jersey breakfast. And I'm like, we have fruit parfaits and we have avocado egg wraps and spinach and egg wraps, no bread. And they're like, oh, and I'm telling them where all the salt is hiding. And they're like, oh, okay, we'll eat the wrap. We understand what you're doing here, lady. So every place that we can get out to raise awareness of good heart health in general, and obviously HCM and thick heart specifically. So, Mike, we got some questions coming in here. I'm going to go back to our dear friend from India who has been patiently waiting. So, Santosh, thanks for stopping in. We can't give a definitive explanation on your management of your HCM, but I'm going to put your question up here, and I'm going to ask some clarifying questions. You have medication. You're on metoprolol succinate, 50 twice a day, and 10 of diflo. Da da da. Under medication, still have palpitation, shortness of breath, intermittent chest pain, disturbing your quality of life. So there's some challenges here. One of those challenges is where you're located, and you are watching us from India, I think you said. So not all of the medical management opportunities that we have in the US and Europe, now in China and heading to Brazil and elsewhere are available in India right now. So there are a few specialists that we work with in India, specifically in Kochi. If you wanted a second opinion, we can help you coordinate there. So on the medical management side, I'll kind of take that first couple sentences and answer it that way. The last thing I'm going to ask is, recently I've been diagnosed with blockages of 40 to 50%. I'm not sure what you're speaking of. Are you speaking of coronary artery blockages, or are you speaking of outflow tract obstruction? And therefore, it wouldn't be percentages, it would be millimeters of mercury. I would encourage you to learn a little bit more about that. Make sure we get the right facts there. And we do provide intake and navigation services outside of the US through a Zoom app. It looks like your English is great, so we can have you do our intake and navigation process and help you understand all of that. So I hope that is helpful. Dr. Emmer, you want to just give any global comments there?
No, what you described there was problems in multiple arenas, some of which were HCM and some were not. So it was a good example of, you really have to take care of the whole picture. People with HCM get coronary artery disease. People with HCM have high LPA, right? And so thinking about the full picture. It's another good reflection as well that there are inequities in the world, right? Not everyone has access to the same things. And so if you can go to an HCM center of excellence, that's fantastic. We highly recommend it, but it's a good example of not everybody has access to all of the same things, which is unfortunate, but we're working towards it.
Fantastic. He's also gene positive with an FHOD3, not one of the more common genes. I would wonder if it's a VUS or a pathogenic. So these are types of questions, Santosh, that we can go through with you on our intake and navigation process, and we would love to speak to you in that manner. Okay, we have some other questions. Deb's back. Will AI provide a retrospective opportunity to identify additional ECG factors that may inform future patient evaluations and screenings? Something that was once benign, like a finding of a right bundle branch block, turns out to be an HCM.
Oh, it's such a good question. I have been engaged in the past and am currently engaged in answering questions like this with some of the AI companies. What we're trying to figure out is, so most of the time the AI instrument's going to give what's called a propensity score. It's going to say, like, here's a score 0 to 100 of how likely I think you have HCM. And when I said cut point, what I was talking about is, the higher you draw that number, the more likely you are to have true positives if you get something back. The next steps are going to be to look at prognoses and how those relate to your score, and to treatment and how that relates to your score. As an example, we know that cardiac myosin inhibitors, in addition to making people feel better, walk further, gradients go down, enzymes get better, they seem to be normalizing ECGs. And so a question BMS is very interested in, and I'm sure Cytokinetics is very interested in, is, as these ECGs normalize, how does that relate to outcomes? How does that relate to heart thickness? How does that relate to how patients feel? And so it's tying these ECG metrics into outcomes. I do think that's where the field is headed. We're kind of baby stepping still. Most people are reluctant to have AI read ECGs at all, but eventually there's going to be a prognostic component to the read.
I think we're hoping for prognostic value to come out from a number of places, including, and now I will do my shameless pitch. You did yours earlier. I will do mine now. The HCMA is incredibly happy to say that we now have IRB approval on our data set. For the 30 years I've been doing this work, I've been keeping notes when I talk to everybody so that when you call back, I know how to help you more effectively. And my team eventually learned how to do that as well as we've grown. So we've taken all of that information and we put it into a REDCap database, very secure, all of the bells and whistles for security and making sure that nobody else has access to your data. And now we can get your consent. So you can call in and you can talk to one of our intake coordinators, or we'll be reaching out to you if you're in our REDCap database. And you can provide consent to give a level of approval for HCMA to use your de-identified information to help inform HCM in the future. So your clinical information that Dr. Ayers has at UVA, that's one set of data. HCMA has been collecting a slightly different group of data from you, but when you put them together, it more clearly identifies where the gaps in care are. Because we're working on two different lines. Doctor says this, patient says that, we're not 100% aligned. How do we get to full alignment? And how do I help answer the question that everybody asks me? What's going to happen to me? And there are things that after 30 years in this space, and after knowing what I know and all the smart people who've taught me and all the community that we have together, we have the guidelines now. So we can kind of predict if this, then that, if this, then that, and where is it going to go? And after a couple hundred patients with HCM, Dr. Ayers, you get a spidey sense for this is looking like it's going this way, and this is looking like it's going that way. Are we 100% definitive on that? No, but we think it's more likely. If you have a preserved left atrial dimension at 50, we're not really worried about you jumping into AFib. But if you're dilated, we're watching, but we can't say it's going to happen.
Right.
Eventually, with enough data in a database of true patient experience, we might be able to help you predict ahead of time before something's going to happen. We don't know that we can stop that thing from happening, but we can allow you to prepare and think about what decisions you might want to make ahead of that. Ultimately, someday, could we evolve to the point of you having enough information to completely change the trajectory of your disease process? That's the ultimate goal. We're not there yet. We may never get there, but we're going to try to inch towards that. And with collective data and cooperation from big partners and friends, we're going to move the ball a lot faster in the next 10 years than the past 10 years. Would you agree?
Yeah, that's 100% right on. I find the majority of patients, not all, but the majority of patients really relish, they really enjoy when I can give precise estimates of here's the probability something happens, and here's how I think treating it changes that probability. I think go ahead.
I hadn't read Madeline's comment before I went on my patient registry explanation and call to action that everybody call us and consent. But this is exactly the kind of question that I'm trying to answer. What can we do as patients to optimize our long-term outcomes in addition to the normal recommendations? As a 33-year-old male, you're a young guy. I don't want your 30s to be like my 30s were. They were hard. I didn't have a lot of treatment options. I was living on beta blockers and calcium channel blockers and trying to raise a family and get through a day with sheer exhaustion. You don't have to do that. We've made things better. So your third generation HCM, you've seen what comes to the other family members and you're on guard because you're trying to avoid it. I hear you. You're post myectomy and you want to do everything to live a better life. That's why the registry is important. That's why you can all call up. Artie is waiting for your calls now, 973-983-7429. Artie, Sabrina, Linda can take your intake and consent you into the registry. We're going to be out at a couple of live events. You'll have the opportunity to provide live registration when we go to Grand Rapids, when we're in Cincinnati, and a couple of other places. So it's really important. So, like, what can they do? What can Madeline do to be her healthiest self? Did we already kind of say it?
Again, what I tell patients, and this is one of my most frequent questions, what can I do to prevent progression? I admit to them that we're not very good at predicting who's going to progress, but I do also tell them there are some things that very clearly seem to go along with progression, maybe not causing, but they sure seem to be associated, like weight, like sleep apnea, like blood pressure. And so what I tell them is, you did nothing to get this HCM. This was just genetics. You didn't do this to yourself. This is just part of who you are. You can't control that, but you can have some control over not getting other medical problems, right? And if you get those medical problems, keeping them under control so that if, heaven forbid, 10 years from now, you're on the transplant list, the transplant team is like, her only problem is HCM. I'm so excited to take her on. The only issue is this thing that she didn't have any control over. What you don't want to be is the person 10 years from now who has uncontrolled diabetes, uncontrolled coronary artery disease, who's a smoker, right? Who has all these other issues, because now you have HCM and all this other stuff that complicates your care. So I say, let me worry about the HCM progression. Let me screen the HCM progression. Keep coming to me. I will keep telling you the most up-to-date things. Don't add problems to this list.
So I think you bring some amazing points to the table, that our health is not just our HCM. No, we didn't do anything wrong. I was giving a talk a couple of weeks ago, and somebody was telling me that they're on beta blockers. It's a suspected HCM out of a crowd that I was talking to. They're on a beta blocker, and they're a smoker. And I said, don't know quite how to tell you this, but I think you're throwing your money out the window twice. Your cigarettes are expensive, and they're making your heart rate go up and your heart beat harder, because that's what nicotine does. And then you're taking a beta blocker that you're also paying for, and it's trying to slow your heart rate. So you're working against each other. Can you talk a little bit about the dynamics of smoking and taking cardiac medications?
Yeah, I not infrequently say to my patients, if you want to know the one thing you could do that made you live longer, it's not coming back to see me. It's not getting a defibrillator. It's not thinking about treating your obstruction. These are good things. I'm not saying don't do these things, but if you want to know one way to live longer, it's stop smoking. Smoking is just gasoline on fires. And if there's even tiny sparks there and you throw gasoline, you got a problem. And so smoking just works against all of our treatments.
To those of you who are actively smoking, we know it's hard to quit.
So hard.
Use all the tools available. We're not here to shame you. We're here to say, this is a thing that you can do. I know it's hard. It's like somebody who has to lose a lot of weight. We know it's hard, but there are things that can help you through that process.
Yep.
So I would encourage you to do that. So we have another note from our friend Santush, who is seeing Dr. Hisham at Emeritus Hospital in Kochi. So I'm so glad that you're connected there. And that is where they will optimize as best they can, explain your symptoms. They're a great team. They are a little limited on what pharmaceuticals they have available to dispense at this time, but work with them. So Tim has an editorial comment for us. I will take this editorial comment, Tim. University of Nebraska should be a center of excellence for hypertrophic, not hypotrophic. I'll get you the typo there, Tim. They have some great doctors. Well, it just so happens that last summer I might have visited a place called Nebraska. Stay tuned for updates. And that's all I'm saying on that one. Okay, Tim has another question. Does Camzyos stop HCM from progression? So I am going to redact your comment here and say, do myosin inhibitors alter progression of disease, with the understanding that we are talking about the myosin inhibitors that are on market today, which would be Mycorrhiza and Camzyos?
What the data for that area shows is that very compellingly and repeatedly, they make people feel better, they make their lab work look better, they make their obstruction get better, and they make them be able to exercise more. Those things anyone who takes care of HCM can tell you those four things. In addition, What you see in some of the imaging subsets is regression of thickness and normalization of left atrial size. The question that remains, and this is something we're trying very hard as a community to answer, is, was it just alleviating obstruction that caused these changes? Or was there something about the treatment itself, independent of the obstruction, that's causing these changes? And do these changes, no matter how we got them, mean I'm going to have fewer events in the future? We don't know the answer to the second two questions, but I think it's pretty reasonable for some people to say, yeah, it seems like it's more than just alleviating obstruction. And yeah, it looks like that's going to change outcomes in the future. So I guess I'm very cautious with my patients as a physician saying this is disease modifying, but I do tell them it's changing cardiac structure in a way that could potentially be disease modifying. It's an exciting time in HCM where there's a bunch of therapies available, right? This is no longer the days of just super high doses of beta blockers, and we're really starting to unpack this. So more to come. Lisa, what do you think?
I think a lot of things on myosin inhibitors. I have some knowledge of those who were in the non-obstructed populations of study. I saw how they did in real life. I saw the outcomes from the trials. It didn't fully connect with me. So I think we had some trial design issues there, because I do think that myosin inhibitors impact the heart muscle in a positive way in HCM to normalize its function, to help it work more normally, hopefully for longer, but we don't have that data yet. So I'm a believer in myosin-based therapies, I guess is the best way I can put that today. Will it be an inhibitor? Will it be a modulator? We just know where the mechanism is that we need to get to now. How we modify that mechanism will evolve over time and understanding, but it ain't a beta blocker. We're not throwing a wet blanket on top of a wet blanket. We are lifting the blanket and we are making things work more normally. And I can't wait until we can have wider distribution of safe myosin inhibitors. Not only I'm optimistic for it in heart failure with preserved ejection fraction. I think there's some work there. So for those who don't know, Dr. Ayers, will you tell them what heart failure with preserved ejection fraction is? Because I might have just dropped some words on people who don't know those words.
So heart failure, terrible term that Lisa and I didn't name, just means shortness of breath due to how your heart is functioning. One classification schema is to say there's reduced pumping action. So that's heart failure with reduced ejection fraction. Not enough forward, you get short of breath. The other problem is that it's like a really thick-walled balloon that takes a lot of pressure to inflate. That pressure backs up to the lungs. It squeezes normally, it just doesn't inflate normally. And so more than half the population now with heart failure has heart failure with preserved ejection fraction, even though historically we've been much more focused on heart failure with reduced ejection fraction. The issue with heart failure with preserved ejection fraction is really twofold. One, the heart is potentially a bystander. It's potentially this metabolic disarray from either weight, lack of exercise, poor blood sugar control, high blood pressure. It's this metabolic disarray that could be causing the heart to have this problem, but the heart itself is not driving the syndrome, right? So that's one problem. The second problem with treating heart failure with preserved ejection fraction is we, as of now, do not have a pure lusotropic agent. Fancy word that means how does the heart relax? We don't have an agent that directly targets making the balloon relax easier. Cardiac myosin inhibitors and myosin modulation are potentially positive lusotropic agents. There's some exciting data out there that I'll let other guests talk about with you, Lisa. But
that would be wise.
We're hopeful that HFpEF, heart failure with preserved ejection fraction, is soon going to have some therapies that speed up relaxation. And that would be a game changer in that space because, again, we've been focused on the metabolic issues more than the actual cardiac mechanism itself.
Love it. Love it. Love it. That makes so much sense. So Tim has a final comment here that I think, given the impending snowstorm coming to the Northeast this weekend, shoveling snow in HCM. It's winter. It's been a hard winter for a lot of people. There's been ice, there's been snow, and you want to go out and shovel it, but heart rate's going up to 163. Any advice for these snow shoveling, big-hearted folks?
I'm actually going to give the same advice that I give almost all of my patients, and that is couch to 5K is not a good idea. What do I mean by that? Being inactive and then becoming very active in a short period of time is a very bad harbinger. It brings stuff that you don't want: sudden death, heart attacks. So if you're somebody who's typically inactive and you're going to go out there and do something very difficult, I would give you caution to move slowly. That's the first word. For obstruction in particular, there are some wonky hemodynamic changes that occur when you've got this mixture of a hard-working heart and very cold environment, and then you get warm very quickly. There's some very funny hemodynamic stuff that makes obstruction particularly symptomatic. And what I tell for my obstructive patients, again, is just like everyone else, you don't want to go from inactive to active super fast. Mm-hmm. But also for you, you've just got to be mindful. If something's really bugging you, stop doing it, right? Don't just push through and finish the driveway, right? I know that the driveway looks better when it's fully finished, not halfway finished, but you've got to listen to your body. You've got to listen to yourself and not push through in those moments, because you could be doing some hemodynamic things that are dangerous.
Okay, we're going to wrap up here in a minute and let our busy doctor get back to work, but we had some, I thought, lovely news. Jennifer, who's a nurse, done a lot of research over 3 years before got her official diagnosis. Welcome to the club. You did not want to join, but now you know you belong here, and it ain't so bad. And she is getting her first supply of my Corso today in the mail. Last week, we did a webinar with the fine people from Cytokinetics talking about their new drug. So if you want to know a little bit more about how you can get my Corso, the patient assistance program was fully discussed in last it was Tuesday. It wasn't last week. It was 3 days ago. I don't even know what day it is anymore. So we did that with Cyto, so you can go take a look at that. I'm glad you were enjoying this podcast. If you want to see this again, all you need to do is go to YouTube, Facebook, LinkedIn. You can watch it anytime. And we are here every Friday at 11 to talk to some of our smart friends about all things HCM, especially on HCM Awareness Day coming up this week. Hello, Stephanie. How are you, my friend? She is one of our transplant buddies. Known her almost 30 years over in the UK. Hope you're doing well. Okay, Dr. Ayers, thank you so much for joining us today. And we navigated our new lines very well.
I think we did well.
Great. Thank you so much. And now I'm going to go pre-record a podcast that will air later with Senator Tony Bucco of New Jersey, and talking about why HCM Awareness Day is important to him personally. Stay tuned for that.
Lisa.
Thank you, Michael. Have a good one. Bye-bye.